All right, hello everybody. We're going to talk about trouble breathing. So this is kind of a part two. Last month we talked about ET, CO2, and shock. So if you haven't seen that lecture, please go back and check it out. It's on Fire Rescue 1 and talks exclusively about capnography and how capnography and shock kind of go hand in hand. Similarly, this is going to be kind of a part two of that series, and we're going to do a deeper dive into specifically respiratory distress. And the reason that we're doing that is respiratory distress obviously is a major call type that we go on, and there's also a ton of different reasons why respiratory distress occurs. And so because that patient is complaining of trouble breathing, complaining of shortness of breath, we have to not approach that with a standard therapy, meaning while we do a pretty in-depth standard assessment, it's going to take us down a bunch of different rabbit holes and to different treatment modalities. Unlike chest pain, where we give them aspirin and potentially nitro, trouble breathing, depending on what's going on with them and their actual diagnosis, is going to differ. And so we have to be very, very cognizant about our assessment, about the subtle signs that's being told to us by the patient, the subtle observations that we see about the patient and the environment, and come up with a treatment plan. And it's not just put them on high flow O2 and transport. That's not going to do them any good. So, in our quest to be better paramedics and better clinical providers, like I said, we're going to do this deeper dive. So what we're going to cover today is we're going to review the anatomy and physiology of the respiratory system. We're going to talk about some different signs and symptoms of acute respiratory distress. We'll do some treatment modalities. So we'll actually come up with treatment plans for some simulated patients within this presentation. And then we'll review those treatment options and talk about what works, what doesn't work, why we should do things, and why we should also avoid certain treatment modes. So again, there's a lot of different causes here. And the big thing is it's a proper diagnosis is the appropriate treatment, right? So we have to figure out why they're having shortness of breath. And that is a complete shift from a lot of EMS education. And even to our senior providers that have been on the department for years and years and years, you've probably been taught or have at least heard at some point that we don't diagnose. And nothing could be further from the truth. We absolutely diagnose every single day. It is in our skill set to provide this, and it needs to be in our skill set to provide this. And the reason is take respiratory distress out of it. Let's talk about diabetes. We show up to a potential diabetic, or an altered mental status, and we check someone's blood glucose, and it comes back low and it says their sugar's 41. We have effectively diagnosed hypoglycemia. We're not going to sit there and tell the patient, well, I think that you might have low blood sugar. We know it's low blood sugar because we can see that. Same thing with a chest pain. So we show up for chest pain, we do an EKG, and it comes across star, 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 meets STEMI criteria. We're not going to sit there and consider it might be a heart attack. It is a heart attack. Well, much in the same way, taking it back to respiratory distress, we can diagnose. And the way that we do that is by using all of our tools and instruments and what the patient's telling us and what the patient's presenting as. So if they're wheezing and they have a high capno value and they're hypoxic to boot and they're tachypnic, so they're breathing fast, that sounds to me an awful lot like bronchoconstriction. And then if they have bronchoconstriction, well, why do they have bronchoconstriction? So we go down that pathway of what causes that. Is it anaphylaxis? Is it asthma? Is it COPD? Because those have very specific treatments above and beyond high flow oxygen. Do they need an EpiPen? Do they need a breathing treatment? So not every patient receives the same exact things. A thorough assessment is the absolute key to coming up with our treatment plans to help our patients in the long run. So again, we have a lot of different causes of respiratory distress, and this list is just a few of them, right? So going through all the different types of ailments, we have viral illnesses, which could include croup, epiglottitis, influenza, bronchitis, RSV. We have traumatic causes, so barotrauma, and that, even think of things like dive injuries. but pulmonary embolisms, pulmonary contusions, broken ribs. We have medical causes, so congestive heart failure. We have asthma, COPD. And don't forget, again, like immunological causes like anaphylaxis, and then, some side effects. So if you're having STEMI, right, you're having a heart attack, you may get some shortness of breath just because your heart's not able to oxygenate and pump effectively. That's going to thus generate hypoxia and some shortness of breath as you're trying to take in more oxygen through a compensatory mechanism. All those are reasons why we might have respiratory distress. And then there's more, right? We didn't even talk about toxicological causes where, hey, did they overdose? Did they inhale something that's maybe a huffing incident, or they're, taking in a computer dust cleaner, or hey, was this a structure fire where they inhaled a bunch of smoke, or is this even something where maybe they were involved in some type of an industrial accident where they've inhaled some type of toxic industrial inhalant? All those are going to be reasons, right? And while those are fairly obvious, again, each one has some different treatment paths. So just to know that there's different causes out there, and that's why we can't have just one standard treatment plan going forward. So when we look at our anatomy and physiology, there's always two parts working together. So we have ventilation, which is air in and air out, and then we have perfusion, which is the oxygenation of cells. They are independent systems that work symbiotically together. So air in, air out is just the passive process of breathing. We could fill an entire room up with propane, zero oxygen in it, and your body would be stupid enough to try to take a breath of that because it's just air in and air out. However, very quickly after doing that, you're going to pass out, asphyxiate, and go unconscious because there is no oxygen in that environment. So that's a very basic example of why we have to have both these systems working together. On top of that, we have to be acutely aware of how our airway works. So remember that we have the upper airway and the lower airway. Where those two kind of split and bifurcate is at the glottic opening. So anything basically above the vocal cords or above the larynx is going to be the upper airway, and anything below that glottic opening is going to be the lower airway. That's why when we're doing basic airway maneuvers, we're talking about the oropharynx, we're talking about the back of the throat, and if we have a foreign body that's below the vocal cords, well, that's why we're not sticking McGill forceps down there, because we could damage a lot of things. That's where we start looking at surgical crikes and things like that. So lower airway problems, we're going to go more invasive. Upper airway, we're going to go more basic, and just kind of understand where those two split at. The airway can also cause respiratory distress. If there's, again, epiglottitis or croup or certain sounds that we'll talk about, but we have to be able to evaluate the airway as a component of your respiratory assessment. At the end of the day, we're looking and identifying not only are they breathing effectively, so air in, air out, do they have good tidal volume? Do they have good chest rise and fall? Do they have good chest expansion? Do I see any intercostal retractions? Those are all ventilation issues. Perfusion is pulse oximetry and capnography. How is their oxygen getting around? Is it perfusing the way it should? Both those systems working together is great, but when one is off from the other, that is a VQ mismatch. We're going to talk more about the VQ mismatch as we go forward, but it is a very highly underutilized assessment tool, and that's the one thing we really need to be looking at here early on in our respiratory patient. So let's talk about our assessment, right? So we get dispatched to a run, we walk in. Our assessment, again, always starts with mentation. You probably do this subconsciously, but we're looking at that patient and we're identifying their mentation. So are they alert? Are they responsive to verbal, responsive to painful, or are they unresponsive? Remember that alert does not mean oriented. Alert just means awake. So they can be alert and confused. They're still alert. They're not oriented to anything, and we have to try to figure that out, but they are awake. There's enough blood and oxygen moving from their heart to their brain to keep them awake and aware of what's kind of going on. Mentation is the first thing because it's easy. If they're unconscious on the ground, we're going to instantly go into a different mode than if you have a person sitting in the recliner, talking to you. that helps us determine if they're sick or not sick. And really, if you think back to like National Registry and your initial EMS training, this is really our transport decision. So we're trying to figure out, is this patient critical or not critical? Do we need to hurry up and do everything right now, or do we not? If they're awake, right, if they're alert, we can probably slow a lot of things down. I say probably because as we go through that assessment, we still need to evaluate airway, breathing, and circulation, and those will kind of determine our treatment mode, right? So when we're looking at the mental status, just know that an altered mental status with acute respiratory distress is a very, very severe sign. That means that they're not perfusing, and specifically, they're not perfusing their brain. That hypoxia is going to such an effect that it's affecting their mentation. That's a pretty severe sign and sometimes even an ominous sign. After we do our mental status from kind of across the room, we're going to examine the airway. And so we're going to listen, right, and talk to the patient. If they can speak back to you in clear sentences, even if it's 1 to 2 word sentences, if it's just clear, then we know that their airway's patent. They have a clear airway, and that's good. But sometimes you'll hear specific airway sounds, and certain sounds can kind of give us a hint to the root cause. So we need to, again, distinguish between the upper and lower airway, what those sounds are. And sometimes we just forget this through the course of our training, or sometimes we just get complacent with airway sounds. But those sounds are going to guide us down a roadmap to get us to the right treatment. We have to note if there's any foreign body and then attempt to clear it. Remember that if your patient is responsive and choking, then abdominal thrust and the Heimlich maneuver are what we need to be doing with them. If they go unresponsive, that patient needs to go to the ground. We need to immediately start CPR. And every single time we go to give a breath, we look in the airway and see if we can clear it out. This is where direct laryngoscopy works. Video laryngoscopy is a good tool as well. One of the downsides with video laryngoscopy in these situations is that if they have a lot of food particles, that's going to gum up the camera at the end. So sometimes direct laryngoscopy is a little bit better, and see if we can pull those objects out with the McGill forceps. If we can't, then we need to continue with CPR and our BLS airway maneuvers, and then start rapidly progressing towards, hey, are we going to crike this patient or not? At the end of the day, we're determining airway patency. So do they have a patent airway or not? If your patient, again, is talking to you, they probably got a patent airway. But just because they have it now, don't forget that, hey, in 10 minutes' time, are they still going to have that patent airway? If their mental status is rapidly declining and they're going to go unconscious, then they're going to lose their airway. Now, does that mean that we need to instantly intubate them and slice their throat open? Absolutely not. It just means that if they go unconscious, we now have an automatic airway issue because of the tongue. The tongue is the #1 cause of airway obstruction, so we may have to place an airway adjunct in order to keep the airway open. So if they're unconscious, we need to be grabbing some type of a BLS airway, whether that's an OPA or a nasopharyngeal airway, but something to kind of hold the tongue in place. Again, the nasal airway is very, very good for also your altered mental status patients. So even if your patient's just drunk, quote unquote, well, even if they are severely intoxicated, can they protect their airway? Sometimes the nasopharyngeal airway will just help to keep that airway open. It's also great on your hypoglycemic patients. It's really, really great for that postictal seizure patient or the actively seizing patient. You can place a nasopharyngeal airway relatively easily, and it just helps keep the tongue off of the, keeps the tongue forward, more anterior, just to keep the airway open. So great devices out there. We need to be using them. So again, talk about airway sounds. The upper airway is going to have kind of 2 main sounds other than clear, which would be nothing. So the #1 thing that we might hear is stridor. So when we hear stridor, that's some type of an obstruction. What's happened is the airway in the upper airway has narrowed. It could be narrowing from some type of a viral or bacterial illness, or because there's actually something physically obstructing the airway itself. In either case, it's going to have this like high-pitched whistling noise because air is trying to push past this random object and it can't. Or because the pipe has gotten much more narrow, again, it can't push through, so it's going to make this whistling sound. It's just a high-pitched, sound. The other sound that you're going to hear is snoring. Obviously, we know what snoring is if you've ever been in the bunk room at any given point in time. But the reason you have snoring is because, again, the tongue will fall into the posterior part of the throat and cause an airway obstruction. So as you're breathing deeply and trying to push past that fat muscular tongue, it's going to just cause snoring respirations. Both of these are to note, and these aren't anything that we should be, glossing over. Like, oh, they have stridor, no big deal. That's a huge deal, and as such, we need to like work on treating that. If they're snoring, that's a huge deal, and we need to either reposition the airway, consider a head tilt chin lift, consider a jaw thrust, and consider placing an adjunct. Conversely, on the lower airway side, we're going to have wheezes, rales, or rhonchi. So if you hear wheezing, that's bronchoconstriction, right? So bronchoconstriction meaning that their bronchi and their bronchiole are much more narrow. That's typically due to asthma. Can also be due to COPD exacerbation. Rales is some type of a fluid, so think pulmonary edema, and that fluid's trapped in the alveoli. And then rhonchi, which is like fluid or phlegm in the bronchi and bronchioles. It's just more centralized in your chest. The reason that these are important is because each one's treated very differently. If we have bronchoconstriction because our bronchioles are narrowed, that means that oxygen cannot get to the alveoli. And recall that your alveoli is the thing you need to be able to exchange oxygen. So when you take in a breath, it goes down your trachea to your bronchi, to your bronchioles, all the way out to your alveoli, which are filled with blood vessels. And that's where oxygen goes onto the blood vessel and where carbon dioxide, the main waste product of your body, comes off the red blood cell and you exhale that. That's why capnography works. We can measure that expired end tidal CO2. If we can't get oxygen to the alveoli because the road to get there is blocked, i.e. bronchoconstriction, it really doesn't matter how much high flow oxygen you put them on, it's not going to get there. We have to administer bronchodilators like albuterol and Atrovent in order to open up the airways in order to supply that oxygen, right? It's basically, we've just kinked the line completely. It's like taking a garden hose and folding it in half. Water does not come out the other end. Water, in this case, being oxygen. You can put them on as much high flow as you want. It is not going to get all the way to where you need it to get to, and thus they're not going to perfuse. If you have rales, it's kind of similar. The road's fine. You'll get oxygen to the alveoli. It just happens to be that those alveoli are completely underwater. And just because similar to you can't breathe underwater, well, neither can your alveoli. So you're not going to have any gas exchange take place because there's fluid literally blocking what that is. And then rhonchi, it's trying to push that oxygen through boogers and snot and mucus and just all that phlegm. Again, it's going to block. It can't go through that stuff. It's dammed up. So we have to find a way to be able to get that oxygen through those obstructions. So once we've assessed the airway, right, we've listened to kind of our sounds, we've evaluated patency, we've looked and seen, hey, do we need a device here? And all this happens in a matter of seconds. This isn't a, what do you think we should do? This is not a slow evaluatory process. This is snap decisions that we're making. We're going to look at breathing. And again, we kind of take this for granted. Being honest, think of yourself and be retroactive a little bit. When was the last time that you actually evaluated lung sounds? So when was the last time you got an accurate lung sound count? So we want to examine the rate, rhythm, and quality of breathing. So how fast are they breathing? Recall that adults breathe about 12 to 20. Kids can be 15 to 25, 15 to 30, and then infants that 25 to 50 mark. And we have to know that. We have to know that at 2 o'clock in the morning when we just got toned out. Because if we are to treat this patient effectively, we have to know what's normal in order to recognize the abnormal. Also, what's their rhythm? Are they breathing in a normal regulatory pattern, which is pretty regular? Or are they gasping and then stop breathing? Are they having apneic spells? Those are all indicative of like head injury. If it's rapid and deep and they're comatose, those might be Kussmaul respirations. And now I might starting to think of like diabetic ketoacidosis or some type of endocrinological cause to this respiratory problem. And then what's the quality? Are they breathing nice deep breaths? Are they getting good tidal volume? Do I see good chest rise and fall? Or are they breathing shallow? Are they having intercostal retractions? Do I see them struggling to breathe? All that has to be evaluated again in a matter of seconds. Does their ventilation need supported, right? If they're breathing good tidal volume, able to exchange words with you, have good conversation, then obviously they're breathing fine. But if it's 1 to 2 word sentences, they're starting to nod off, they're super cyanotic, hey, we might have to take over this breathing here in a minute. And if you don't, be prepared for you to take it over in about 2 minutes when they actually go unconscious on you. Do we see any JVD? So jugular venous distension. Again, when was the last time that we actually evaluated for that? But when you see big, fat, engorged neck veins, that is a problem with circulation. That's a problem to where blood is not returning to central circulation. So there's some type of an obstruction there. If I see JVD, I'm starting to immediately think congestive heart failure. I'm starting to immediately think pulmonary embolism. And so because of the presence of that, and also a tension pneumothorax will do it too, I'm starting to evaluate and rule out those 3 causes. And do I see good symmetrical chest rise and fall? Again, sometimes it's painfully obvious. Like if a person is, smacked by a car and they have a flail chest segment, we're going to see asymmetrical chest rise and fall. And the call type will kind of lead us down this route too. If we go to a trauma emergency, we're going to be thinking more trauma-centric than in medical run. What's the odds someone has a pneumothorax from a medical cause? However, it does happen. I've seen it in our own organization. It's super rare, but it does occur. So we have to kind of have this global assessment of breathing on every single one of our patients. So again, talk about that VQ mismatch. As we're evaluating breathing and we're evaluating the airway, we're looking basically to see, do we have a VQ mismatch? Remember that V is ventilation, so are they breathing? And Q is perfusion. And the reason Q stands for perfusion is reasons. There's no reason whatsoever. It just is what it is. So we're looking to see, is there a VQ mismatch? Recall from the previous lecture that if my patient's breathing, say, 20 to 24 times a minute, they're breathing a little fast. Well, knowing nothing else about medicine, if I'm breathing faster, that means I should be taking in more oxygen. So if I'm breathing faster, my pulse ox should be 99 to 100%. However, if I'm breathing faster and my pulse ox is low, below 94%, then that is a VQ mismatch. I'm breathing faster, but I'm not taking in oxygen. And our next question after we identify that is, why? Why are they not doing that? And that starts to lead us down the rabbit holes to figure out the actual cause and start treating our patient. This is why pulse ox and capnography both need to go on our respiratory patients. So we apply pulse ox because it's a great tool. It's very easy to apply. But once we determine that they're hypoxic, capnography has to immediately go on. Whether the capnography is high or low will kind of also put us down some different treatment paths. We also want to obtain a 12-lead EKG because I want to see, hey, if they're hypoxic, do they also have ischemic heart issues? I'm looking for depression in my anterior lateral leads. I'm looking for depression in my inferior leads because that depression means that my heart is now stressed. Not only you're not perfusing your organs, you're not perfusing the cells of your heart, which also probably means you're not perfusing the cells of your brain. So we're having some heart stress, we're having some mental status stress. So that's why we want to get that 12-lead EKG. It's not because, oh, we're seeing if they have a STEMI. That's part of it too. But we're seeing what this hypoxia is actually doing to our patient. So get that 12-lead early. And then finally, let's put them on oxygen, right? We know there's a VQ mismatch here, right? We know they're not perfusing. They need oxygen. So let's put them on it. And we'll talk about how much and why and what we should choose here in just a little bit. So then we're looking at circulation, right? So just like we talked about with your breathing, we're going to look at rate, rhythm, and quality of your pulses. We identify any central or peripheral cyanosis. So we're looking for cyanosis around the nail beds, around the lips or the mucous membranes. We look for any major bleeds. Again, those could be painfully obvious to note, right? Again, person hit by a car, they're probably going to have major bleeds. But don't rule out major bleeds from medical causes, i.e. a GI bleed for a patient on blood thinners. Blood loss is blood loss, whether that's internal or external. It doesn't have to be from gunshot wounds. It can be from very benign medical causes. But if they're bleeding out internally because of a lower GI bleed or esophageal varices or what have you, or maybe they took a fall and they've had major bleeding going on in their belly or in their abdomen, then that's going to affect perfusion because they're bleeding out. Their cells aren't able to carry oxygen throughout the entire body. That's going to create a VQ mismatch. That's going to create dyspnea and tachypnea and all these issues with respiratory distress. So what that does is helps us rule out suspicion of trauma. So even though we're on a chest pain, don't forget to consider in the back of your mind traumatic causes. Don't forget to consider internal bleeding as a potential cause. So let's go down the rabbit hole, right? So we do our mental status, airway, breathing, circulation. We determine if they're sick or not sick. And also we don't talk enough about the whole borderline concept where, hey, they're pretty bad off, but they can wait a minute, right? Or, hey, they're not really critical, but they're not that great. That's that borderline concept. And that's where a transport decision that we need to make, where we need to treat aggressively, but we got a little bit of time. But based on all these exam findings, we're going to determine a treatment path. Remember, not everyone has to get high flow O2. Some patients don't need a non-rebreather mask. Some people need a nasal cannula. Some people need CPAP. Some people need bag. So the big thing here is for us to slow down and, for lack of a better term, take a breath. So while we're throwing everything but the kitchen sink at our patients, we have to, as good clinical providers and good EMS professionals, figure out what are we seeing and what path are we taking? Do I have bronchoconstriction? Do I have stridor? Do I have rales? Because each one means something different. So let's look at one of our patients, right? So we got a 78-year-old female, calls us for shortness of breath. She's been having trouble breathing for a day and a half. She's a past smoker. She states she cannot catch her breath. She's alert and oriented with a patent airway. She's tachypnic at 26 times a minute. She's got some shallow inspirations, and we note no cyanosis. So we walk in, and that's our general impression, right? She's sitting in a chair. She's just, speaking like, I just can't get my breath. And nice little old lady, past smoker, probably has a couple cats. We don't see any cyanosis. She's breathing a little fast, but she's got a good airway. Is she sick or not? Probably looking at this patient, we'd say, not that sick. Obviously, she's sick, she needs to go to the hospital, but should she die in the next 30 seconds? Probably not, right? And if she does, then something went horrifically wrong. She's mentating, she's alert and oriented, which means, again, there's enough blood and oxygen going from her heart to her brain. That's good. She's not doing good overall. This is not someone you get a refusal on by any stretch, but she's considered for us non-critical. She's not sick. But is she borderline? She's got some pretty rapid respirations. She's outside the norm. She's got some shallow inspiration. So even though she's breathing fast, she's not breathing well. Her tidal volume is low. She's not taking big, deep breaths. And so again, the question here has to be, why? So we probably get on some oxygen. We get some vitals, and we see her blood pressure here of 116/76. Nothing too remarkable there. Relatively normal. One thing to consider here, though, is that, that's a normal blood pressure for an adult, but she's 78, and she's a past smoker. How many past smokers and how many elderly people do you know that have really, really good blood pressures? Maybe that's on the lower side of her, because most past smokers and a lot of older adults are hypertensive. They usually run 140, 150, 160 systolic. But this one's 116/76. That's a subtle sign for us as an EMS professional to say, hey, that's not hypotension, but maybe it's hypotensive for her. She's also tachycardic. She's at 126, so that's got to be concerning. She's breathing 26 times. She's shallow and labored with a pulse ox of 91%. We can see here there's a VQ mismatch. She's breathing fast, 26 times a minute, and she's hypoxic. So there is, in fact, a VQ mismatch present. And if there is a VQ mismatch present, this is a respiratory patient until proven otherwise. There could be other things going on too, but this is, in fact, a respiratory patient and must be treated as such. Do we consider here a blood glucose? So some people would advocate yes for thoroughness. Some people would advocate no because it doesn't really matter. She's alert and oriented. I'd advocate to use your best judgment. The reason I would want to get a glucose on this patient is to see, hey, are we dealing with some type of diabetic ketoacidosis? Now, we're likely not because she's breathing shallow. If she was breathing rapid and deep, I would really consider a blood glucose here, but it's not going to hurt her, but it's also not the thing. This is a respiratory patient. So we put her on a monitor and we see an AFib, and then our 12 lead is unremarkable. This is a good sign. So even though she's an AFib and a rapid AFib, our 12 lead is good, right? So we're not seeing any ischemia. By now, we're probably starting to think what it might be. And so we get capnography on it. Capnography is 28. And it being low is a really, really bad sign. So if it was high, we'd start listening to lung sounds and we'd start considering bronchoconstriction or maybe rales. But again, recall that capnography values that are low are early signs of shock. Just like we talked about where we've been taught for years we don't diagnose, the other thing we've been taught in EMS, which isn't necessarily bad, is treat the patient, not the monitor. Treat the patient, not the monitor. Meaning, hey, we see a rapid AFib. We don't need to start reaching for drugs right now. We can talk to this patient. She's stable. The caveat to that is the one thing you will treat the monitor for is low capnography. You cannot fake this vital sign. All right, so this patient with a low capno value, that's real. And that is an early sign of compensatory shock. This is an early sign of compensated shock. So if we think she might be in shock, then we also have to figure out what kind of shock is she in and why. Again, the first part of this lecture kind of talks about that with the ETCO2 and shock. But that needs to be in our head that, hey, she might be progressing into shock. So we do some further history, and she says, well, I fell into a bedside table yesterday morning. Oh, okay, big deal, right? She tripped and fell. So we reach for lung sounds, and we do some breath sounds, and we hear them diminished on the right side. What's she got now? So if we go back and we think of this patient that presents with acute shortness of breath, maybe some of us were thinking COPD, maybe we were thinking, oh, we'll just give them some high flow and take her to the hospital. But when in fact, this patient has diminished lung sounds on one side. She actually has a pneumothorax from a very benign fall. So it's a simple pneumothorax progressing to a tension. Now we're in a whole different ballgame. This is why high flow O2 and transport does not work. We have to take a second and do a thorough assessment to figure out the exact cause. We have to closely monitor her vital signs, because as she's progressing towards tension, there's a good chance that her vitals will continue to fall or other things start to occur there. She's an early compensated obstructive shock, 100%. And if this tension gets worse, we might need to be prepared to decompress her. So even though this isn't a massive motor vehicle crash with ejection and this car flipped multiple times or whatever, this isn't penetrating trauma. This is a very benign little old lady who trips, falls into a bedside table, and probably punctured her lung with a rib. Then maybe broke something, maybe didn't, but at the end of the day, she's got a pneumothorax. And so that's why we listed the lung sounds. So let's look at another patient. We got a 38-year-old male with sudden onset shortness of breath. He's, again, alert and oriented, but through gasping breath states that he absolutely does not feel right. He clutches his chest and feels as though he might pass out. He's got a patent airway. He's breathing rapidly and deep, 30 breaths a minute. He's pale and diaphoretic, and there is no cyanosis present. So again, if we walk through this assessment, he's alert and oriented. So while this sounds bad, he's got enough blood and oxygen going to his head, right? He's got enough blood and oxygen that's keeping him alert and oriented. And even though he's working really, really hard, sick or not sick, he's sick, but is he going to die in the next 30 seconds? Realistically, should not. He might feel like he doesn't, but we got a few seconds of time here before he's going to crash. So get him to the squad. He's clutching his chest. He might pass out. Like, the other thing here to consider is this an anxiety attack? And the answer is absolutely not. This is not an anxiety attack. He's pale, he's diaphoretic. Even though he feels like he might pass out and he's gasping, this absolutely is not a panic attack. We get a BP of 128/74, heart rate of 126. He's breathing, again, 30 times a minute with an SpO2 of 90%. And this is why this is not a panic attack. Panic attacks do not give you hypoxia, right? If anything, it gives you more oxygen because you're hyperventilating. It'll give you hypocarbia. Your CO2 will fall, but it will not give you hypoxia. So here we have a VQ mismatch. And once again, if we have a VQ mismatch, we have a respiratory patient until proven otherwise. So there's a CAPNO value of 25, which again is a sign of possible shock. He's got a normal temp, and this started 30 minutes ago. He's got clear lung sounds. And we do an EKG, and it's unremarkable. So now we have to ask ourselves, why? Why would his CAPNO value be low? Well, if that's a sign of shock, well, what kind of shock could he be in? So we consider trauma. Well, assuming he hasn't been shot multiple times or he doesn't have GI bleeds or anything, it's not hypovolemia. He's got a normal temp. He hasn't been sick, so that kind of rules out sepsis. He doesn't have any hives on him, so that's no anaphylaxis. He didn't see something bad and pass out and wake back up, so psychogenic's out. He didn't fall and break his back, so that's not neurogenic. So as we start kind of working down the list, we've come to the conclusion that, hey, this is obstructive shock. Well, the three things that cause obstructive shock are one's a cardiac tamponade, one's a tension pneumothorax, and the other one that we often overlook is the pulmonary embolism. So this is exactly what this patient's having is a PE. Why he threw a clot, who knows? Maybe he was on a long travel. Maybe he just has a history of it. But this guy has a pulmonary embolism. So this guy does need high flow O2 and transport. And be prepared to augment that O2 therapy. So while he's on a non-rebreather, that might not do it the best justice that we could. We're going to use a non-rebreather, but hey, don't be surprised if you're going to be CPAPing this patient here very soon. The other thing we have to do here is rapid notification to the ER. Let the hospital know, hey, I'm coming in with this patient. Here's my vitals, and I think it's a PE. Our docs will listen to us. And that starts to just ready things at the hospital. It just might clue that doc in to, hey, I'm going to get respiratory involved. I'm going to go ahead and get x-ray involved. This patient is facing a life-threatening complication. This pulmonary embolism might kill him. And so the faster we can order those resources up, the better, in theory, their longevity is going to be and their morbidity and mortality starts to go down. Now, at the end of the day, that doc might say, I don't believe you, and we're not going to deal with that, but we'll just take that one as it goes. But again, if we have good relationships with our physicians because we are good professional EMS providers, they listen to what you say on that squad phone. So it's not uncommon for you to have to call this up and say, hey, doc, I think this is what this is. So again, the big thing here is that it's not a panic attack. So panic attacks don't have a VQ mismatch. They're breathing fast, but their oxygen's terrific. So that's not a VQ mismatch. There's no hypoxia. They'll have carpopedal spasms, right, where their hands and their feet kind of crimp up. They also just don't seem to respond to you, right, as they're shaking or trembling, or as you talk to them, nothing really works. That's because of a lack of CO2. They've hyperventilated and blown all their CO2 off. So the treatment to a panic attack is to actually get them to slow down their breathing. And one tip that really works well that I've had great success with over the years is have your patient hold their breath. So we don't want to give them a brown paper bag and breathe into that, or, don't put them on a non-rebreather because that doesn't really do anything. They're not hypoxic. You can just have them hold their breath. And so the longer they hold their breath, as you count to maybe 10, slowly, quietly, calmly, they'll exhale. But every time they hold that breath in, they hold back CO2. And as we get their CO2 back to normal levels, which again are 35 to 45, then at that point, they'll kind of come back into homeostasis. Their spasms will release. They'll be able to mentate, talk to you. It goes better. They will be tachycardic, but they'll have clear lung sounds, right? Because there's not a respiratory component here. They're called for trouble breathing, but that's not the thing. They're having a panic attack. Conversely, the respiratory patient has a VQ mismatch. They're breathing fast, but their oxygen's low. They're hypoxic. They could be hypocarbic, but they could be hypercarbic. So they could be above 45 torr. They could be below 35 torr. Remember, 35 to 45 being our range for capnography. They're going to be tachycardic and tachypnic, so they're going to be breathing fast with fast heart rates. And they'll have adventitious lung sounds, meaning they're going to have wheezing, rales, rhonchi, snoring, stridor. They're going to have weird airway sounds coming out of them. Panic attack patients aren't going to have that. So let's look at another patient here. So we got a 6-year-old male with a productive cough and shortness of breath over the last day per his parents. Child appears alert and oriented, but he appears sluggish and lethargic. The child's breathing rate is slightly elevated, but you can hear audible whistling sound as they inhale and exhale. There are no major bleeds and there is no cyanosis. So even talking to the family in the living room of this house, probably at 11:30 or 12 o'clock at night, we're hearing this weird whistling sound, which if we remember back is stridor. So we got a blood pressure of 100/60, pulse rate of 110, respirations of 25, and his O2 sats 93. So again, sick or not sick? Really not that sick. You know, it's not great, but he's not going to crash on you in the next 30 seconds. He's got a temp of 103.8, and we hear this audible stridor and a barking like cough. The barking like cough, I threw into this PowerPoint just to kind of give it away, but not every kid's going to have that, but he's got clear lung sounds bilaterally. So what's wrong with him? Well, hopefully you said croup, because the natural thing is that barking like cough. Typically what happens is these kids cough and cough and cough and cough and cough, like whooping cough almost to a certain point, and then they'll take a big rapid inhale, and that's where you hear that stridor sounds. And as they cough and cough and cough some more, you'll hear that stridor expiratory wheezes going. It could be RSV, it could be some other viral illness, but for us, we don't really care. Like, we don't care if it's croup or we don't care if it's RSV, because we're going to treat this as a viral respiratory illness. In this case, we're going to need supportive O2 therapy. Now, a lot of people would say, well, let's give him a breathing treatment. We need to give him a breathing treatment. Well, remember, he doesn't have bronchoconstriction. So really, the breathing treatment, well, it's not going to hurt him. It's really also not going to help him. What this kid needs is nebulized oxygen, which a lot of people will say, well, we don't give nebulized oxygen. We don't have humidifiers. Well, you don't need one. What we need is take your handheld nebulizer that you put a breathing treatment in and just squirt like 5 cc's of saline from a saline flush into it and then administer it. So all it is just nebulized saline. And it's going to help to break that stuff open. And it's no different than when you take a croup kid out into the fall night air, like we see in our EMS textbooks. That's all you're dealing here is cool, moist air. What that's going to do is relax the swelling in his upper airway. It's just going to kind of have a cooling sensation there. It's going to continue to make him cough, but it's just going to make his throat feel better. Big thing with this kid is to be mindful of his mental status. So while he's alert and oriented, he's sluggish and lethargic because he's sick. We're not just going to shrug that off. That's actually a very subtle sign that while his mental status is good for now, we need to keep a close eye on this over the course of our transport. Be prepared for him to potentially start to decompensate, because the parents are reporting he's had trouble breathing for the last day, but he might have been dealing with this for the last 3. For those of us with kids, how often do they actually come and tell us their problems right away? Some other causes that might be going on, other causes of stridor is epiglottitis. So epiglottitis, the way that you can kind of differentiate that from croup or RSV is that epiglottitis has a very rapid onset. So croup and some other viral illnesses, even like COVID, they take a while to come on. So that come on, or influenza will come on over the course of a few days. Epiglottitis comes on over the course of a day, and it just spikes a fever. So instead of a gradual ramp up, it's a fever right now. A lot of epiglottitis kids will seize because of a febrile seizure, but the other thing that they do is they just drool. And what happens is epiglottitis, your epiglottis is actually inflamed, it's swollen. And because it's swollen, you cannot swallow. So all their saliva that you just naturally have in your mucous membranes instead of going down or being absorbed, it just drools out of you. So they sit forward, tripoding. Their shortness of breath is because their epiglottis is so big and fat. Well, the more they cry or scream or have anything that happens, that's going to continue to swell up. So we want to keep these kids as comfortable as possible. This is where blow-by oxygen is a good idea. Not that blow-by oxygen is a great idea for anything, but this is that time to, hey, let's just have some little bit of blow-by. Maybe the kid stays in mom's lap, just to keep the kid calm. Dim the lights in the squad, establish a rapport, and just let mom nurse that kid or whoever all the way to the hospital. Don't forget foreign body airway obstruction, like we talked about earlier. And don't forget smoke inhalation or airway burns. Those will cause stridor too. So if a victim is in a house fire and takes in a lot of superheated gas, that's again going to cause upper airway swelling, and that's going to cause potential airway burns. And then airway trauma itself. So a hanging, a strangulation, or a clothesline injury. So if someone's running, gets clothesline, that's going to cause some type of crush injury to the trachea, and that can cause stridor because you've narrowed the pipe. Hanging and strangulation does the same thing. Strangulation also can be not just coming behind someone, choking someone out, but also just think domestic violence and things like that, or even just any type of physical altercation or assault. How often are we assessing the airway on those patients? So let's look at another one. So we got a 66-year-old male with acute dyspnea, or acute difficulty breathing. He appears alert and oriented, sits forward in a tripod position with pursed lip breathing. His airway's patent. You note intercostal retractions in his neck, chest, and abdomen. So he's really working hard. He appears pale. His skin is dry. He's a known smoker and states that this has gotten worse over the last 2 days. He speaks in 2 to 3 word sentences. So again, sick or not sick? Well, he appears alert and oriented. So once again, he's got enough blood and oxygen going from his heart to his head. But he's really working hard, right? He's got pursed lip breathing. I mean, he's almost making us like a kissy duck face. And your COPD patients will do that because they're creating a pressure differential in their chest. As they're trying to push that oxygen out, they're keeping their alveoli open. It's a biological sign to try to do that. This guy's fighting to keep breathing. He's pulling every muscle that he has to try to make his chest work. He's doing this involuntarily. So it's not like he's actually got to physically think about flexing these muscles. His body's doing this automatically just to try to draw in oxygen. So this is a very, very sick patient. He's not going to crash in the next 30 seconds, but in the next 5 to 10, we need to start working on that. So he's got a blood pressure of 168/74. His heart rate's 125. He's got a respiratory rate of 28. His pulse ox is 87. He's got audible wheezes and rhonchi. He's got some occasional PVCs. And there's no elevation in his 12 lead, but he's got pathologic Q waves. And what pathologic Q waves are, those are post-STEMI markers. So he's probably had a heart attack before, and now that's a permanent marker on his 12 lead that he'll see. He doesn't have a fever, but his CAPNO's 57. So what are we seeing here? We have a VQ mismatch. He's got a high respiratory rate with a low pulse ox. But instead of the other patients having a high or a low CAPNO value, his is elevated. He's hypercarbic. What that means to us is that oxygen is not getting to the alveoli, but that also means that CO2 is not getting out. He's retaining all the CO2 in his body because he cannot exhale it out. That means that the road to get to the alveoli is blocked. This guy, because of his wheezes, because of his rhonchi, and most importantly, because of his CAPNO values, this guy has acute bronchoconstriction. So this guy's got COPD exacerbation. His COPD, or his chronic obstructive pulmonary disease, is really, really, really bad. He's bronchoconstricted down, so he needs bronchodilators and steroids. The other patients, not so much. But this is the guy that absolutely needs albuterol, Atrovent, and let's get going. We should establish IV access if possible. A lot of these patients are kind of hard sticks, and be prepared to switch oxygen delivery methods, right? So this guy might have already been on a cannula before. This is where, hey, we might need to be going to a non-rebreather. Recall that you can modify our non-rebreather masks into a simple face mask with a nebulizer. So to do that, you're going to rip off the actual bag part of the non-rebreather, just have the mask. And instead of using the T part of the nebulizer with the handheld part, you're just going to take the nebulizer chamber and jam it up into the mask through the hole that was created, and then hook up your high flow O2. You're going to flow this at about 10 liters per minute and start working. In this kind of a patient too, and it's not indicated, but it's just good field craft, we know that one breathing treatment is not going to help this guy. So if we know that one's not going to work, why don't we just fire 2 breathing treatments into the nebulizer? At the end of the day, he's going to take in the dose he has just by breathing. But whether the nebulizer runs for 10 minutes or 20 minutes doesn't really affect him. So a good option here is, hey, instead of 1 albuterol, 1 Atrovent, do 2 albuterols and 1 Atrovent, and that's just going to let the breathing treatment work longer. It's going to get an extra dose in because we know that this patient's really, really sick and needs that. So here's the protocol for asthma COPD. So again, 16 years in age or older, they've got worsening shortness of breath. We hear wheezing, rales, rhonchi, or poor air exchange. So they can also be super diminished and tight wheezes. They are normal sinus or TAC or AFib. We don't see any bradycardia here. So they talk about with the EMTs, making sure that you have an inhaler. But for us, we're going to administer albuterol and then Atrovent. So we can substitute Duaneb with that. So we're down in medic section G. If they have impending respiratory failure, get an IV, right? Because we're going to need to start pushing some other drugs here pretty soon if they're in impending respiratory failure. Again, if we anticipate multiple albuterol treatments, start to get our steroids on board. So in this case of this patient, he's super full, he's super constricted. So he's going to need multiple albuterol treatments. So we're also going to give Solu-Medrol. We can give prednisone, 60 milligrams orally, so 3 tablets, which is fine. Or since we already have that IV access, we're going to go ahead and crush down our Solu-Medrol and draw that up, which is 125 milligrams IV. Start thinking about CPAP if we need to. And if it continues to be worse and we're not getting any effect, there is the option in here to do racemic epi. There's also the option of giving epi 1 to 1,000 at 0.3 milligrams, followed by mag sulfate 2 grams in 100 cc's of normal saline over 20 minutes. That's really, really, really deep in the weeds, but it is an option for us for basically status asthmaticus. So it's not just the asthma patient, it's the status patient that's not getting any benefit from the breathing treatments. For us, that's super rare because by this point, we're likely at the hospital. Again, consider positive airway pressure, so consider our CPAP stuff. And again, the big thing is our medical history is going to tell us what this is. This is a COPD patient, but looking at their med history and looking at their medications they're on is going to kind of distinguish, is it COPD or is it CHF? Be prepared for them to have some more tachycardia. That's a known side effect, so that's why we want that 12 lead again, because as we're stressing the heart out a little more, we're going to ramp up the speed. We want to make sure that we're not causing any ischemic or myocardial damage with that. So that's why we do a 12 lead. There's other things that cause bronchoconstriction out there besides COPD. Again, we talked about asthma and status asthmaticus, but also don't forget anaphylaxis. So big thing is look for hives in history. So my patient's got acute shortness of breath, their cat nose high, they're breathing fast, their pulse ox is low. Lift up their shirt and look. If I see hives everywhere, then that's not asthma. That's anaphylaxis. Look at history. Did they, how long has this been going on? In this case for this patient, it's been going on for about a day or two. Well, that's not anaphylaxis. But if this started like 15 minutes ago, now I'm starting to think this is pretty sudden. Start thinking anaphylaxis. Did they complain of being stung by a bee? Did they get exposed to some type of foodborne thing that they're allergic to? So hives in history are going to also help to differentiate the two, because one is a respiratory patient The other is an immunologic emergency, and we need to give epi fast. So let's talk oxygen delivery devices real quick. So when we look at oxygen delivery devices, we're looking at first at our nasal cannula. So the nasal cannula is supportive therapy or mild hypoxia. This means that you must have good tidal volume, meaning good chest rise and fall. If they're having shortness of breath and they cannot take good deep breaths, this nasal cannula is not going to work for them. It is a great device for non-respiratory patients, i.e. strokes, STEMI, supportive care. Hey, they're on home O2 and they took a fall. Keep them on it. We use a nasal cannula all the time. In fact, it's attached to our capnography. The other thing we want to do, though, is make sure that we're titrating our therapy. So instead of just putting on high flow O2 and kind of forgetting about it, we really don't want them to get to 100%. The reason we don't want that is too much oxygen in a medical patient can cause further harm, specifically for strokes and STEMIs. Your pulse ox is only calibrated to read at 100%. But if I put you on oxygen, there's a good chance you're saturating like 108%. You might say, well, how's that? Well, it's because our atmosphere is 21% oxygen, and that gives me 99% on a pulse ox. What happens when I have you breathe 100% oxygen? You're going to have more in your system. At the molecular level, what that does is exposes you to this thing called free radicals, and that's basically these extra oxygen molecules floating through your bloodstream bind to different chemicals that you have, iron, calcium, things like that, and that creates these free radicals that float around. That causes further injury. So for stroke patients, high flow O2, not indicated unless they're hypoxic. And if they're hypoxic at like 93%, we only want their oxygen to get to 99, 98. Just get it above 95, honestly. They're doing fine. That's normal. STEMI patients, high flow oxygen by non-rebreather mask is not indicated. Titrate your therapy above 95% to 99%. We want them to be what's called normoxemic. So we want your patients to be at a normal pulse ox that they would normally be at to minimize the chance of further myocardial or further brain injury from this extra oxygen molecules floating around. So that's a major change that guys have to understand when we're dealing with our respiratory patients and just medical patients in general. This does not apply in trauma. So we have a trauma patient. You might say, well, oxygen will do the same thing in the body. Yes, it will. However, in a trauma patient who's bleeding out, either internally or externally, we've lost a lot of our hemoglobin, right? Our red blood cells have spilled out of our body onto the pavement, into our body, wherever, because we are cut, we're bleeding, we're shot, we're having a blunt force trauma, whatever. So because of that, high flow oxygen is indicated for a trauma patient. Not so with medical. So let's talk about that non-rebreather. So moderate to severe hypoxia, you're below 90% typically. So anywhere above 90%, that's where we're into that nasal cannula range again. It's great for that initial stabilization, right? So if they have severe respiratory distress, absolutely get that non-rebreather on them. They have to have good, adequate tidal volume. So again, they got to be breathing spontaneously to take that oxygen in. Again, terrific for trauma patients because, again, your blood is spilled out somewhere. So let's saturate and oversaturate what blood you have left in you. So as we're plugging the holes and we're stopping the bleeds, it's great to oversaturate those molecules to keep perfusion going. And then we can start kind of backing off of it. But for trauma patients, non-rebreather mask is totally indicated. Not so with strokes and STEMIs, though. Then we have the CPAP. So as we kind of ramp up our system, this is kind of our third oxygen delivery device. This is severe hypoxia with diminished tidal volume. So our patient's no longer in respiratory distress here. They're not just short of breath. They're not having difficulty breathing. they cannot breathe. They're in respiratory failure, meaning their system is failing, it's collapsing, and we're quickly on the downhill slide to respiratory arrest. To use CPAP, they have to be able to follow commands. They can be altered, right? They can be responsive to verbal. They can be confused because they're hypoxic, but they have to at least be able to follow commands. This is not indicated for trauma patients. Again, do not put a trauma patient on CPAP because if they have a chest wall injury like a pneumothorax, it's going to make that a lot worse. You're basically blowing oxygen continuously into these patients. That's just going to fill that chest cavity up with more and more air and cause a tension pneumothorax to get significantly worse. That's going to cause cardiovascular compromise. That's going to cause dysrhythmia. That's going to cause them to die. So do not put them on a CPAP. It is the thing for CHF, so congestive heart failure, and it is the thing for severe COPD patients. So if I've got CHF or COPD, CPAP is the bee's knees that we want to put them on if it's severe. If we can get by with a non-rebreather, if we can get by with a cannula and a handheld nebulizer, then let's do that. But if those treatments aren't working, be prepared to ramp up here to CPAP. And then finally, we have the bag valve mask, which is our only device for respiratory arrest. Again, if they're not breathing, CPAP does nothing. If they're not breathing, a non-rebreather does nothing. So this is the only thing that allows for ventilation. If we're bagging somebody, we must begin to incorporate a BLS airway adjunct. So the reason for that is because, again, the tongue. They've gone unconscious. Their tongue has fallen to the posterior part of the throat. So let's get a BLS airway adjunct in, whether that's a nasopharyngeal, whether that's an oral airway, or are we going to go to an advanced airway procedure, which is fine. Direct laryngoscopy, video laryngoscopy, fire an eye gel into them. And what determines that is going to be gag reflex, right? So we put an OPA in, they gag. Cool, we're going to go to a nasopharyngeal. You put an oral in, and they don't gag. Now we start thinking, hey, should I just tube them? Might as well. You absolutely can do that. Things to consider with that is how big are they? If we have a very larger patient, an obese patient, then hey, that intubation attempt going to be the best idea for them, or are you really going to struggle with it? If we can get good compliance with an OPA, do that. At the same time, if you want to try and fire a tube in and you think you can make it, do that as well. A lot of these COPD patients and CHF patients have been intubated before. So we're doing nothing new to them that hasn't already occurred, all with the objective of oxygenating them and restoring and getting rid of the VQ mismatch. When we're bagging, avoid hyperventilation. So make sure we're bagging at a normal rate. So typical rate for a code is 8 to 10 times a minute. But these patients haven't coded yet. So again, we want to consider one breath every 5 to 6 seconds. I hate ranges, so I'll just do 10 breaths a minute. So just bag them at 10 breaths a minute. That's one breath every 6 seconds. If they need a little more, give them a little more. It's going to be subjective. So just make sure that we're avoiding hyperventilation and giving them nice, good breaths to get good chest rise and fall. Maintain steady rates. So I don't want to give 3 big breaths and then stop breathing for 30 seconds and 2 more breaths. I want a nice, steady rate, 1 breath every 5 to 6 seconds. Looking for that chest rise and fall. And make sure we're using the right BVM. So we have 3 sizes. We have the adult and we have the child, which are carried in the airway compartments. And then we also have the infant size and a child size, which are in the PD bag. So if we have a infant, 3-month-old who's not breathing, we want to make sure we're using the infant BVM. Make sure that if we have an adult in cardiac arrest or in respiratory arrest, that we didn't accidentally grab the child BVM. They look very similar. Our labels change. So just take a quick second if you're assigned to that airway person, just to make sure you have the right tools for the right job. So our last patient we're going to cover, we have a 67-year-old male who presents with sudden onset shortness of breath over the last 2 hours. He's anxious, he's sitting upright, he's alert and oriented. He speaks in 1 to 2 word sentences and states he is going to die. He further clutches his chest. His airway is patent and self-maintained, and while his breathing is rapid, shallow, and very labored. He appears flushed and diaphoretic, so he's got like super reddened skin with noted JVD. So what do we have here? Well, it's super reddened skin. We might start thinking like carbon monoxide poisoning. That's not always the case, right? If he had it and his wife has it and his kids have it, then maybe that's CO poisoning, but he's not complaining of headache. We're not complaining of flu-like symptoms, so that's pretty uncommon there. But the big thing is he says he thinks he's going to die. When patients say that, they typically mean it. So this isn't a panic attack again. This is something pretty legit. While he's alert and oriented, he's speaking in 1 to 2 word sentences. He's got enough blood and oxygen for now going from his heart to his head. But how much longer is he able to hold this up? In this case, this patient's pretty sick. He's going to start crashing. So we got a blood pressure of 178 over 126. His heart rate's 85. Respirations are 38 and extremely labored with a pulse ox of 87%. We listen to his lungs. We have rales bilaterally. His 3 lead shows runs of trigeminy, and 12 lead shows ischemia, but no elevation. So this guy's stressing his heart. He's probably stressing his head. He's pretty bad off. So what are we going to do here? Well, we could fire a non-rebreather on him, but again, his tidal volume is so poor, his respirations are so shallow that non-rebreather is not really going to work, or at least not for very long. We might say, well, we need to do rapid transport. 100% agree. But if we just fire a non-rebreather on and beat feet to the hospital, he's going to die en route. We have to get this patient stabilized before we go. So then we can say, well, we could bag him because he's breathing so fast, we need to ventilate him. We could, but ventilating a still breathing patient is very, very, very difficult. So we have a better device. The other thing is, do we have a VQ mismatch? Absolutely we do. His capnography is 67, super high. It's got a normal temp. And as we're evaluating him, his mentation starts to slip towards a verbal response. So he starts nodding and going in and out. Here's an example of his EKG. We're not going to go into like what his EKG is, but anyone can look at this and say that this doesn't look good, right? He's got some just kind of funky QRS complexes going on. What looks like PVCs. A couple of these leads, it just doesn't look good. No elevation, but just not a good tracing. Very irregular. So what's he got? He's got pulmonary edema. And looking at his med history, it's likely congestive heart failure. But again, we're not going to rule out some other things. So it could be drug use. Years ago, I had a patient who smoked crack, and that in turn will cause flash pulmonary edema. Again, toxic inhalants like ammonia will cause flash pulmonary edema. So while this patient wasn't working at Tyson Foods, those are still things to consider, right? Again, painfully obvious, but don't be shocked when flash pulmonary edema occurs. In this case, it is congestive heart failure. What you're seeing in the image is an X-ray, and the black parts of the X-ray are the lungs, and then we have all this white stuff, kind of cloudy stuff in the middle. That's not supposed to be there. That white stuff in the middle that looks kind of like a film, that's fluid. And that fluid is running all the way up and down their body, and it's just completely saturating and blocking the alveoli from working. Furthermore, if you lay these patients flat, be prepared for them to rapidly arrest, because you're going to take the fluid that, as they're sitting up, that fluid is being pulled to the bottom of their lungs from gravity. As soon as you lay them flat, that fluid washes out all the surfactant and washes into all their alveoli. So when that occurs, they're just going to respiratory arrest on you. So keep them sitting up. Do not lay them flat, or be prepared for a lot of work. The key to this is CPAP. So we need to administer CPAP quickly, or be prepared to bag them because he's already crashing. Because it's congestive heart failure, also consider high-dose nitroglycerin. So our typical nitro dose is 0.04 milligrams sublingual. We're going to double that. Instead of giving 1 tablet, we're going to give 2 under the tongue. So what that's going to do is hopefully open them up a little bit more and reduce what's called pulmonary hypertension. That's the pressure that your heart's pumping against to try to get oxygenation to occur. Again, we want to do a rapid transport and very early notification to the ER. We want to probably go to a trauma bay, and we probably want respiratory on standby to get them off CPAP and get them to something more permanent. So again, looking at our protocol, they got to be 16 years of age or older, breathing faster than 20 times a minute with rails. If we look at it, they might have COPD or asthma, but we consider our nitro. So again, less than 100. Make sure they haven't taken any ED meds or erectile dysfunction meds. Look at their 12-lead EKG, get an IV access going. Low dose nitro is 0.4 milligrams. And then for moderate to severe symptoms, again, high dose nitro, which is 0.8 milligrams sublingual, or that 2 tablets, every 3 to 5 minutes for a max of 3 doses. So instead of giving 3 nitro tablets to our chest pain patients, these guys are going to get 6, 2 every 5 minutes, and do not remove CPAP to provide additional doses if possible, meaning don't discontinue CPAP. You can take it off, fire it under the tongue, and put it right back on. That's not removing CPAP. Don't take CPAP off and see what it does. That's not good. Nitro paste might work as well. We don't carry nitro paste as well. But basically, again, the big thing is looking at their history to determine what is this COPD or is this asthma. Looking at the protocol for positive airway pressure. So this is for CPAP itself. So how to put it on and basically kind of what we're looking at. We want them to be on capnography. They need to be on capnography. Also, make sure that when we place that capnography on them, it's not going to break the mask seal, so ours do not. Make sure that we check for air leaks. And the big thing is start with our settings of 5 to 10 centimeters of water. So on our CPAPs, on the front is a little dial. And we want to start at 5. And if it's really severe, go up to like 7.5. And it's really severe, start at 10. You want to typically start low and work high. So as you're transporting, if it's not getting any better, just increase it by 1 notch. So start at 5, go to 7.5, then go to 10. You might want to consider Versed. So, a lot of these patients are going to be anxious, and they're not anxious because they're claustrophobic, although that's in a lot of literature. They're anxious because they're hypoxic. They're not getting oxygen to their brain anymore. They're crashing. So typically, as you're giving them oxygen via CPAP, they start to calm down a little bit. The Versed just helps that hypoxia to allow you to work. So consider 1 to 2 milligrams of Versed, IV, IM, or IO, or IN. And the odds of us IO in a patient are pretty slim. The big thing is reassessing them and making sure that we're increasing our positive airway pressure as needed based on how they're providing their symptoms. In this case, our patient becomes unresponsive. So what now, right? So again, the protocol says do not remove CPAP unless this happens. So if they go unresponsive, get that CPAP off of them. Immediately remove it, do a full recheck of their ABCs, and start BVM ventilations. Apply the pads, prepare for CPR, and get the Lucas out. So even though they might still have a pulse, they ain't going to have one for very long. So that's kind of our progression of this CPAP patient, right? He's crashed. Go ahead and get CPAP on or CPAP off. Start bagging, get an airway, and then again notify the hospital of your change in responsiveness. Fortunately for us, this patient survives. You get to the ER. They were able to get him fully resuscitated, even though he coded. He sits up, and this guy made a full recovery, all because of the fruits of your effort. So wrapping this up, again, there are a lot of different causes of respiratory distress. Most of our treatments are going to be supportive in nature. A breathing treatment opens up the bronchioles to allow oxygen to be delivered to the alveoli. The nebulized saline is really, really supportive in croup. Passive oxygen devices like a nasal cannula are great for certain medical interventions. However, there were certain therapies that are absolutely beneficial, i.e. CPAP. Therefore, we must have a good assessment. We can't just CPAP every person under the sun, and not every single person needs a breathing treatment. It all goes back to the assessment. Mental status first, then airway, breathing, circulation. And when we determine problems, such as locating a VQ mismatch, then that's where we have to pause and ask ourselves, why do they have this? And just work down the rabbit hole. As we just go through a good assessment and go through our treatment modalities, that's going to lead us to a good, positive diagnosis and ultimately a good treatment plan and a positive patient care outcome. That's the purpose of this drill, to be good professional EMS providers and ultimately to go out there and save lives. At the end of this, if anyone has any questions, do not feel ashamed to get a hold of me. I'd love to talk and nerd out more about this with you. That being said, if you have anything, get a hold of me. Thanks for watching, guys. Bye.